After studying this module, you shall be able to understand the term disorder and its relevance in the psychogeriatrics, know the different types of disorders as classified by the DSM, identify the major anxiety disorders associated with the elderly, understand the onset and causes of anxiety disorders in the elderly, evaluate the treatment method for anxiety disorders. In layman terms, disorder may be defined as the state of confusion, a disruption in the systematic functioning of things. When some event does not proceed in the predefined or orderly manner, we say that a state of disorder prevails. In the field of psychology, the term disorder generally refers to a disturbance in the normal functioning of the mind, involving thoughts, emotions and behavior that cause significant distress to the self and others. In this sense, it may be said that it is a thought, emotion or behavior that is deviant from the accepted social criterion. However, it is important to note that not all emotion, thoughts and behaviors that may be seen as deviating from the usual are disorders. The differences may also be due to differences in the intelligence levels of a set of individuals, or say differences in the creative ability of a few individuals, which enables them to think out of the box and think of new ways to perform the same given action. Hence, researchers have concluded that only those emotions, thoughts and behaviors which are seen as maladaptive, that is, can cause and maintain emotional problems, may be considered as disorders. Psychologists have identified many types of disorders which have been enlisted officially in the two classification systems, the DSM and the ICD. The versions DSM-4-TR and ICD-10 are being presently used for the purpose of diagnosis world over. The most common enlisted disorders are 1. Adjustment disorders. The DSM-4 identifies these disorders as the ones that are related to an identifiable source of stress that causes significant emotional and behavioral symptoms. The diagnostic criteria for adjustment disorders include A. That which creates significant impairment in work, school or social environments. B. That which involves distress that is in excess from what would be expected from the stressor. If the above stated symptoms occur within 3 months of exposure to the stressor, then the prevailing state may be classified as an adjustment disorder. 2. Anxiety disorders. The term anxiety is defined as a diffuse, vague, very unpleasant feeling of fear and apprehension. The anxious individual also shows combinations of the following symptoms: rapid heart rate, shortness of breath, diarrhea, loss of appetite, fainting spells, dizziness, sweating, sleeplessness, frequent urination and tremors. Hence, the group of psychiatric conditions that involve anxiety are known as anxiety disorders. These are characterized by some sort of fear, tension or worry, which may be excessive and sometimes even abnormal. The Anxiety Disorders Association of America has identified following 5 anxiety disorders: A. Panic disorder. B. Obsessive-Compulsive Disorder (OCD). C. Post-traumatic stress disorder (PTSD). D. Generalized anxiety disorder (GAD). E. Phobias including social phobia. 3. Dissociative disorders. Dissociation is defined as the act of disconnection or separation. In psychology, dissociation can be viewed as severance of the connections between ideas and emotions. In psychology, dissociation can be viewed as severance of the connections between ideas and emotions. Dissociation involves feelings of unreality, estrangement, depersonalization, and sometimes a loss or shift of identity. Sudden temporary alterations of consciousness that blot out painful experiences are the defining characteristics of dissociative disorders. Dissociative disorders are hence those which involve dissociation or an interruption in the aspects such as consciousness, including memory and identity. The 4 major dissociative disorders are: A. Dissociative amnesia, B. Dissociative fugue, C. Dissociative identity disorder, D. Depersonalization. 4. Eating disorders. Eating disorders are characterized by obsessive concerns with the weight and disruptive eating patterns that negatively impact physical and the mental health. While eating disorders may begin with preoccupations with food and weight, they are most often about much more than food. Eating disorders arise from a variety of physical, emotional, social, and familial issues, all of which need to be addressed for effective prevention and treatment. Eating disorders are real, complex, and devastating conditions that can have serious consequences for health, productivity, and relationships. These are conditions that can lead to significant physiological changes that require medical treatment in addition to psychiatric treatment. The major eating disorders are A. Anorexia nervosa, B. Bulimia nervosa, C. Binge eating. 5. Impulse control disorders. Impulse control disorders are those that involve an inability to control impulses, resulting in harm to oneself or others. Types of impulse control disorders include A. Kleptomania, stealing, B. Pyromania, fire starting, C. Trichotillomania, hair pulling, D. Pathological gambling, E. Intermittent explosive disorder, D. Dermatillomania, skin picking. 6. Mood disorders. These disorders, also called affective disorders, involve persistent feelings of sadness or periods of feeling overly happy, or fluctuations from extreme happiness to extreme sadness. Examples of mood disorders include A. Bipolar disorder, B. Major depressive disorder, C. Cyclothymic disorder. 7. Neurocognitive disorders. These psychological disorders are those that involve cognitive abilities such as memory, problem solving, and perception. Some anxiety disorders, mood disorders, and psychotic disorders are classified as cognitive disorders. Types of cognitive disorders include A. Alzheimer's disease, B. Delirium, C. Dementia, D. Amnesia. 8. Neurodevelopmental disorders. Developmental disorders, also referred to as childhood disorders, are those that are typically diagnosed during infancy, childhood, or adolescence. These psychological disorders include A. Intellectual disability or intellectual developmental disorder, formerly referred to as mental retardation, B. Learning disabilities, C. Communication disorder, D. Autism, E. Attention deficit hyperactivity disorder, ADHD, F. Conduct disorder, G. Oppositional defiant disorder, ODD. 9th, personality disorders. People with personality disorders have extreme and inflexible personality traits that are distressing to the person and or cause problems in work, school, or social relationships. In addition, the person's patterns of thinking and behavior significantly differ from the expectations of society and are so rigid that they interfere with the person's ability to function effectively. Personality disorders create a maladaptive pattern of thoughts, feeling, and behaviors that can cause serious determinants to relationships and other life areas. Types of personality disorders include A. Antisocial personality disorder, B. Borderline personality disorder, C. Obsessive-Compulsive personality disorder, D. Paranoid personality disorder. 10th, psychotic disorders. Psychotic disorders are those that involve a loss of contact with the reality. These disorders involve distorted awareness and thinking patterns. People experiencing psychotic disorders may experience hallucinations and often display disorganized thinking. Delusional beliefs are another common characteristic of this class of psychological disorders. Types of psychotic disorders include A. Schizophrenia, B. Delusional disorder. A characteristic symptom of schizophrenia is hallucinations, that is, the experience of images and sounds that are not real, such as hearing voices and seeing objects or persons which are not physically present. Schizophrenia has hence often been referred to as the most dramatic psychological disorder. 11th, somatoform disorders. Somatoform disorders is a class of psychological disorders that involves physical symptoms that do not have a physical cause. These symptoms usually mimic real diseases or injuries. It is important to note that somatoform disorders differ from the fictitious disorders. People suffering from somatoform disorders are not faking their symptoms. Somatoform disorders include A. Conversion disorder, B. Somatization disorder, C. Hypochondriasis, D. Body dysmorphic disorder, E. Pain disorder. 12th, substance-related disorders. Substance-related disorders are those that involve the use and abuse of different substances such as cocaine, methamphetamine, opiates and alcohol. These disorders can include dependence, abuse, psychosis, anxiety, intoxication, delirium and withdrawal that results from the use of various substances. Examples of substance-related psychological disorders include A. Alcohol abuse, B. Caffeine-induced anxiety disorder, C. Cocaine withdrawal, D. Inhalant abuse. In this module, anxiety disorders will be discussed. Some of the other enlisted disorders, especially related to the elderly, like dementia, Alzheimer's and alcohol abuse in the elderly, will be discussed in the other modules. The anxiety disorders. Anxiety disorders have anxiety as the primary symptom. The National Institute of Mental Health, NIMH, in USA defines anxiety disorder as the ones which occur as a result of excessive and abnormal anxiety levels which begin to interfere with an individual's day-to-day living. Such a situation, if prolonged, may hamper the individual's ability to lead a normal life. NIMH identifies a wide variety of anxiety disorders, including post-traumatic stress disorder, obsessive-compulsive disorder, and panic disorder, to name a few. As an individual's age advances, the sources of anxiety may also increase, as the aging individuals now also need to worry about their future after retirement, their medical expenses, whether they would be a burden on their family, and the like. Also, anxieties about the death begin to surface. Leicester in 1967 had conducted a study on the death anxiety among aging people and found that a higher fear of death existed in the elderly subjects with more inconsistent attitudes towards death, while subjects with less inconsistent attitude reported a lower fear of death. Beacom and his colleagues conducted a longitudinal aging study in 1998 on 3,107 older adults in the Amsterdam to study the anxiety disorders in later life. They found that anxiety disorders are common in later life, with the most common disorders being GAD, generalized anxiety disorder, with 7.3%, followed by phobic disorders 3.1%. However, obsessive-compulsive disorder 0.6% was rare. Causes of anxiety disorder? Many causes have been identified for anxiety disorders by both scientists and psychologists. Some of the most common causes are 1. Gender. With the exception of obsessive-compulsive disorder (OCD), women have twice the risk for most anxiety disorders as men. 2. Age. Phobias, OCD and separation anxiety typically show up early in the childhood, while social phobia and panic disorder often develop during the teen years. Phobias and panic disorders have been found to resurface in the old age. 3. Traumatic events. Traumatic events can trigger anxiety disorders, particularly post-traumatic stress disorder. 4. Mental conditions. Although causal relationships have not been established, certain medical conditions have been associated with the increased risk of panic disorder. They include migraines, obstructive sleep apnea, mitral valve prolapse, irritable bowel syndrome, chronic fatigue syndrome, and premenstrual syndrome. Onset of the anxiety in the elderly. Among older adults, anxiety is a common illness. Anxiety affects as many as 10 to 20% of the older population, though it may often go undiagnosed. The most typical type of anxiety disorder in this age group is phobia. When an individual is fearful of certain objects, places or events, among adult women, anxiety is most common mental health problem, while it is the second most common for men after substance abuse. Any symptom takes the form of a disorder only if it persists over a period of time. With intervention, the symptoms may be controlled on time and they may not interfere in the daily functioning of the individual. With the geriatric population, however, this is a common challenge. Older adults with anxiety and related disorders often go undiagnosed and hence untreated because of one or many of the following reasons. 1. Failure to recognize the existence of the symptoms. 2. Reluctance to discuss their feelings with their family or friends. 3. Reluctance to discuss their feelings with the physician. 4. Failure to accept their loss of independence and the consequent growing dependence on others for even the most basic everyday needs. 5. Acceptance of anxiety as the usual state of being rather than as something unusual. Anxiety, like any other disorder, is left untreated, can lead to serious impairments in the everyday life of the individuals. Untreated anxiety can lead to several conditions such as poor physical, mental and psychological health, cognitive impairments, impairments in one's social life and the workplace. An overly anxious individual may also experience a loss of self-esteem and self-confidence. This may in turn lead to a deteriorating self-image, and thus the individual may start doubting his or her own self-worth. Hence, if left untreated, overwhelming feelings of anxiety may also lead to depression in some cases. This then leads to deterioration in the individual's overall quality of life. This is particularly so for the geriatric population, so they are already experiencing low self-esteem due to the loss of social and financial status as a result of retirement. Common anxiety disorders in the geriatric population. Panic disorders. Panic disorder is characterized by periodic attacks of intense anxiety or terror. Panic attacks usually last 15 to 30 minutes, although residual effects can persist much longer. People with this condition have feeling of terror that strikes suddenly and repeatedly, with no warning. Panic attacks can occur in nearly every anxiety disorder, not just panic disorder. In other anxiety disorders, however, there is always a cue or specific trigger for the attack. A diagnosis of panic disorder is made under the following conditions. A person experiences at least 2 recurrent unexpected panic attacks. For at least a month following the attacks, the person fears that another will occur. Symptoms of a panic attack. During a panic attack, a person feels intense fear or discomfort and experiences at least 4 or more of the following symptoms: rapid heart rate, sweating, shakiness, shortness of breath, a choking feeling or a feeling of being smothered, dizziness, nausea, feelings of unreality, numbness, either hot flashes or chills, chest pain, a fear of dying, a fear of going insane. Raj and his colleagues conducted a study in 1993 to determine the prevalence, clinical characteristic and possible factors that may facilitate a late onset of panic disorders among 540 patients aged 60 plus years. The results of this study showed that the late onset group experienced more shortness of breath during panic attacks and were more likely to have medical disorders like chronic obstructive pulmonary diseases, vertigo, Parkinson's disease, while the early onset group was more socially phobic and more depressed. Phobias. According to the American Psychiatric Association (APA), a phobia is an irrational and excessive fear of an object or situation. In most cases, the phobia involves a sense of endangerment or a fear of harm. However, in reality, it poses little or no actual danger. It is normal and even helpful to experience fear in dangerous situations. Fear is an important adaptive human response. It serves as a protective purpose, activating the automatic fight or flight response. With our bodies and minds alert and ready for action, we are able to respond quickly and protect ourselves. But with phobias, the threat is greatly exaggerated or non-existent. Symptoms of phobia. The symptoms of a phobia can range from the mild feelings of apprehension and anxiety to a full-blown panic attack. Typically, the closer we are to the object we are afraid of, the greater will be our fear. The level of fear that an individual experiences will also be higher if getting away is difficult. Phobic symptoms can occur through exposure to the feared object or situation, or sometimes simply thinking about the feared object can lead to a response. The most common phobias are animal phobias. Examples include fear of snakes, fear of spiders, fear of rodents and fear of dogs. Natural environment phobias. Examples: fear of heights, fear of storms, fear of water, fear of the dark. Situational phobias. Fear triggered by a specific situation. Examples include fear of enclosed spaces, claustrophobia, fear of flying, fear of driving, fear of tunnels, and fear of bridges. Blood injection injury phobia, the fear of blood, fear or injury, or a fear of needles or other medical procedures. Common symptoms associated with phobias include A. Physical signs and symptoms of a phobia: difficulty in breathing, racing or pounding heart, chest pain or tightness, trembling or shaking, feeling dizzy or lightheaded, a churning stomach, hot or cold flashes, tingling sensations, sweating. B. Emotional signs and symptoms of a phobia: feeling of overwhelming anxiety or panic, feeling an intense need to escape, feeling unreal or detached from self, fear of losing control or going crazy, feelings as if you're going to die or pass out, knowing that you are overreacting but feeling powerless to control your fear. J. Lindsay in 1991 studied phobic disorders in a sample of 60 confirmed cases of phobic disorder, identified in an urban elderly community sample, and 60 controls matched pairwise for age and sex. The results of the study showed that the onset of agoraphobic fears, fear of open spaces in old age, was attributed by most cases to an episode of physical illness or other traumatic events. Increased rates of palpitation, giddiness and tinnitus not attributable to anxiety were identified in the cases. Obsessive-Compulsive Disorder (OCD). Obsessive-Compulsive Disorder (OCD) is a condition marked by unwanted, intrusive and repeated thoughts, obsessions and behavior compulsions. People with OCD are plagued by constant thoughts or fears that cause them to perform certain rituals or routines. The distributing thoughts are called obsessions and the rituals are called compulsions. A critical feature in this disorder is an inflated sense of responsibility, in which the patient's thoughts center on possible dangers and an urgent need to do something about them. Over half of the patients with OCD have obsessive thoughts without the ritualistic compulsive behavior, although they recognize that the obsessive thoughts and ritualized behavior patterns are senseless and excessive. They are unable to stop them. OCD often accompanies depression or other anxiety disorders. Some patients find that their symptoms subside over time, while others experience a worsening of symptoms. Obsessions are recurrent and persistent mental images, thoughts or ideas. The obsessive thoughts or images can range from mundane worries about whether one has locked a door to bizarre and frightening fantasies of behaving violently towards a loved one. Compulsions are repeated, rigid and self-directed routines that are intended to prevent the manifestation of an associated obsession. Such compulsive acts might include repetitive checking for locked doors or unlit stove burners, or calls to loved ones at frequent intervals to be sure that they are safe. Some people are compelled to wash their hands every few minutes or to spend inordinate amounts of time cleaning their surroundings in order to subdue the fear of contagion. All these are examples of compulsive behaviors. In this disorder, the sufferer experiences intrusive thoughts, the obsessions, which are the source of anxiety. However, the anxiety can only be relieved by performing an often ritualistic act, the compulsion. It is important to note that the compulsion does not necessarily have to be logical, related to the obsession. The only requirement is that for whatever reason, it relieves the anxiety generated by the obsession. Treatment of anxiety disorders. The standard approach to treating most anxiety disorders is a combination of talk therapy, such as cognitive behavioral therapy (CBT) and an anti-anxiety medication. The most widely prescribed class of anxiolytic drugs are the benzodiazepines. The first benzodiazepines were released in the 1960s and are now the drugs of choice for treatment of acute anxiety. These drugs are easily absorbed and hence work quickly. Another class of drugs which were used earlier, the barbiturates, are no longer used today. A healthy lifestyle that includes regular exercise, adequate rest and good nutrition can also help to reduce the impact of anxiety. According to Nikki Solberg, in 2012 for the geriatric population, that is people over 60 years of age suffering from OCD, even though no sure-shot cure has yet been found, scientists and psychologists have been looking at various techniques to help solve this problem. So far, the medical practitioners have reported that talking to a trained psychologist has been found to be helpful. The psychologist helps the patient to think about what is causing the obsessive and or the compulsive behavior, and hence think rationally as to whether that behavior needs to be continued or discontinued. Another method of treatment which has been found to be effective to a great extent is the ERP, exposure and response prevention. The person is exposed to the anxiety-provoking situation in a safe and supportive environment where he is prevented from responding to the compulsive behavior. The rationale is that when the person realizes that by not indulging in the compulsive acts, no negative outcome has occurred, it would reduce the compulsive behavior. Solberg also says that a type of medicine has been reported to be helpful for the people with OCD. This is called the selective serotonin reuptake inhibitor, SSRI. An SSRI is a medicine that works in the brain and stops serotonin from going back into the releasing cell too quickly. Serotonin is a brain chemical that can be low in people with OCD. This means that one needs more serotonin in the brain cells to help make one's OCD more manageable. Out of all of the many SSRI medicines, doctors have found that most people with OCD feel the best with a medicine called fluoxetine. However, recent research points to a more eclectic approach, with each person needing a different approach. Summary: in psychology, the term disorder generally refers to a disturbance in the normal functioning of the mind involving thoughts, emotions and behavior, causing significant distress to self and to others. Those emotions, thoughts and behaviors that are considered maladaptive, that is causing and maintaining emotional problems, may be considered as disorders. DSM-4-TR and ICD-10 are the official classification system used for the diagnosis of disorders the world over. One of the anxiety disorders given in the classification system are the anxiety disorders. The National Institute of Mental Health (NIMH) in USA defines anxiety disorders as ones which occur due to excessive and abnormal amounts of anxiety which interferes with the functioning of the individual. Anxiety is the primary symptom of these disorders. Various causes of anxiety have been identified by experts. Some of the common causes are gender, age, traumatic events and medical conditions. Anxiety disorders are quite common among the elderly and affects as many as 10 to 20% of the older population. However, anxiety disorders among older adults often go undiagnosed due to overlap of symptoms with physical disorders and hence remain untreated. Most typical form of anxiety disorders among the elderly is phobias, where an individual has an irrational fear of certain objects, places or events. Another common type of anxiety disorder among the geriatric population is panic disorders. Panic disorder is characterized by periodic episodes of acute anxiety which usually lasts 15 to 30 minutes. Obsessive-Compulsive Disorder (OCD) is also a common anxiety disorder among the elderly. It is marked by unwanted, intrusive and repeated thoughts, obsessions resulting in repetitive behaviors, compulsions. These compulsive behavior get reinforced as they help in reducing the anxiety generated by the obsessions. The standard approach to treating most anxiety disorders is the combination, counseling and anti-anxiety drugs.